Okay, you can go ahead.
All right. By way of introduction, cardiac channelopathies are inherited disorders. They are inherited disorders associated with life-threatening ventricular arrhythmias, and these are caused by genetic mutation of ion channels that alter cardiac cell membrane potential. They have varied presentation, ranging from sudden cardiac death to incidental diagnosis on routine electrocardiogram. So the various cardiac channelopathies are mainly classified into 6. We have the long QT syndrome, the short QT syndrome, Brugada syndrome, catecholaminergic polymorphic ventricular tachycardia, idiopathic ventricular fibrillation, and early repolarization syndrome. But for the purpose of this presentation, I'll be talking about long and short QT syndrome. So definition: long QT syndrome is a group of cardiac channelopathies characterized by delayed repolarization of the myocardium resulting in heart-corrected QT prolongation, usually greater than 480 milliseconds, while short QT syndrome is an inherited cardiac channelopathy that is characterized by an abnormally short QT, less than 320 milliseconds, and an increased risk is associated with an increased risk of atrial and ventricular arrhythmias. Epidemiology: sudden cardiac death occurs in about 50% of all, is responsible for 50% of all cardiovascular deaths, and in the Western world, coronary artery disease is responsible for 75 to 80% of sudden cardiac death. But in young individuals, the commonest causes are primary electrical diseases, cardiomyopathies, and myocarditis. So inherited electrical diseases or structural non-ischemic disease account for 50% of sudden cardiac death in individuals less than 50 years, while arrhythmic disorders like long and short QT syndrome account for only 1 to 2% of sudden cardiac death in the Western world. So the estimated prevalence of long QT syndrome is approximately 1 in 2,500 individuals, and the prevalence of short QT syndrome is about 0.02 to 0.1% with a male predominance. So this is a picture showing a bar chart rather, showing the incidence of sudden cardiac death in the Western world. And New Zealand, you can see that from the bar chart that New Zealand,
Go give them one, let them go with it.
have the highest cases of sudden cardiac death per 100,000. So this is a picture showing the action potential, and we can see an ECG. The first image shows an ECG. Usually the cardiac action potential is represented by an ECG, and the P wave represent atrial depolarization. Then there's a PR interval before the QRS complex, which represent ventricular depolarization, and then we have the T wave, which represents ventricular repolarization. So this is mediated by mechanisms. The mechanism responsible for this tracing involves both inward and outward ions, and these are controlled by voltage-gated channels. So there are 4 phases in the action potential. We have phase 0, phase 1, phase 2, phase 3, and phase 4. So phase 0 represents a rapid upstroke, which is usually mediated by inward sodium channels, which causes rapid depolarization in the myocardial cells. Then we have the phase 1, which is the spike, and this is mediated by transient outward potassium channel, which is controlled by, we have the fast and the slow transient potassium channels. Then we have phase 2, which is the plateau phase, and this phase is mediated by calcium channel, inward flow of calcium channel. The phase 3 indicates further repolarization, And this is mediated by a balance between the inward calcium channel and then the delayed rectifier potassium channels, which allows the outward flow of potassium channel outside the cell. And these include IKR, IKS. Then we have phase 4, where the action potential returns back to the usual, returns back. So this is mediated by the inward rectifying potassium channel, IKS, and then sodium potassium ATPase, and then sodium calcium pump. So there are 4 main or 5 main outward channels. We have the ITO, the IKS, IKR. IKI is usually an inward, it's more of, this channel allows more potassium into the cell than it allows it outward. Then there are 2 inward channels, INA, which is a sodium channel, and then ICAL, that's calcium channel. So this is summarized in this table. Phase 0, rapid depolarization. Phase 1, early repolarization. Phase 2, action potential plateau. Then we have the final repolarization, and then phase 4, resting membrane. The resting membrane potential is restored. So this is just a picture showing the various segments and the waves of the ECG. We have the P wave, the PR interval, the QRS complex, the ST segment, and then the QT. For the purpose of this presentation, we're more interested in the QT interval, which begins from the end of the beginning of the Q wave to the end of the T wave. So there are different formulas. There are different formulas and different ways of calculating the QT interval, but it's at the intersection of the T wave maximum slope with the isoelectric line is most appropriate, and it's most accurate when QT interval is being calculated. So from the beginning of the Q wave to the end of the T wave. So the various formulas available have the Behzet formula, the Fredericia formula, Framingham's formula, the Hodges formula, but the Behzet formula is the one that is we commonly use, and it's easier to use. However, it's best for heart rates between 60 to 100 or 120. So any heart rate outside that, it's really not accurate. And if a heart rate is less than 60, it's advised that the actual QT interval will be used rather than the heart rate corrected QT interval. So the normal QT values by age and gender using the Behzet formula, we have for adults, males less than usually less than 430, for adult females less than 450 is prolonged if it's greater than 470 for females, and then 450 for males. Long QT syndrome, congenital long QT syndrome is an inherited arrhythmic disorder, and it's characterized by delayed depolarization of the ventricular myocardium, and it manifests as prolonged heart rate corrected QT interval, which leads to dangerous arrhythmias like Torsades de Pointes and eventually sudden cardiac death. So a brief historical background. In 1957, long QT was first reported, and it was said to be responsible for sudden cardiac death in congenitally deaf children, while in 1964, families, it was noticed that families with long QT syndrome had sudden cardiac death, but this time around they didn't have deafness. While in 1971, left sympathectomy, which is one of the modalities for treating long QT syndrome, was identified. While in 1980, research on genetic mechanism of long QT syndrome started, and then the gene was finally identified by 1995. So the prevalence of long QT syndrome is difficult to estimate because we don't have, especially in our environment where we don't really have data for this. However, approximately 1 in 2,500 to 1 in 10,000 individuals are affected, and it is more common in females, especially long QT syndrome 2 and 3. It usually presents with cardiac events in childhood, adolescence, or early adulthood. The molecular mechanism for long QT syndrome, usually electrical activity are generated from the SA node, which leads to the normal action potential generation. But if there is a genetic mutation involving this ion channel, usually for long QT syndrome, there is a loss of function mutation of the inward of the delayed rectifier potassium channels, and then a gain of function mutation of the sodium and calcium channel. So this mutation in ion channel will lead to prolonged depolarization or increased repolarization current, and this will lead to QT prolongation. So over 600 mutations have been recognized involving 17 genes, but the commonest ones are long QT syndrome 1, 2, and 3, which accounts for more than 95% of genotype positive long QT syndrome patients and account for 75% of all patients with long QT syndrome. The most commonest pattern of inheritance is usually autosomal dominance. That's the Romaine-Ward syndrome, and then the Javelin-Nelson syndrome is inherited as an autosomal recessive fashion and is usually associated with congenital deafness. So the mutation causing long QT syndrome affect genes that code both potassium and sodium channels. And this will lead to a decrease in the repolarizing potassium currents during phase 3 of the action potential. And because it allows persistent inward sodium currents resulting in prolongation of the action potential. So these are the various, this is a table showing the classification of the of long QT syndrome, the commonest ones being long QT syndrome 1, in which the genetic mutation involves the KCNQ1 gene. And the protein affected is the IKS potassium channel. For long QT syndrome 2, KCNH2 gene is affected, and this will lead to, and the protein affected is the IKR potassium channel. While for SCN5A, long QT syndrome 3 is the cardiac sodium alpha subunit that is affected. Then there are other ones like Andersen-Tawil syndrome, where the IKI potassium channel is affected, and then Ankyrin B syndrome, and then the Timothy syndrome also. But these ones are rare. So the pathophysiologic mechanism of long QT syndrome involves the figure A shows the normal action potential, while B shows the various ions and the channels involved in the various phases of the action potential. For phase 0 is sodium channel. For phase 1 is the fast and slow transient outward potassium channel, while for phase 2 is both sodium and calcium channel, and then phase 3 is the delayed outward rectifier potassium channel, IKR and IKS, and then phase 4 is the delayed inward rectifying potassium channel, IKI. So the picture in D shows what happens in long QT syndrome. There is a reduction. There's a reduction in the outward potassium channels. That's the delayed rectifier potassium channel, IKR and IKS, and then increase. So there's a loss of function mutation in the delayed rectifier potassium channel, and then a gain of function mutation in the sodium and calcium channel. So what this does is that it prolongs the action potential by preventing or delaying repolarization. So if there is a gain of function mutation in sodium channel, and then also loss of function mutation in the potassium channel, the same thing, repolarization is delayed. The same applies for the inward calcium channels. gain of function mutation involving the inward calcium channel, and then there's decrease in the outward flow of potassium channel will also prolong the action potential. So increased sodium channel, increased sodium ion, increased calcium ion, decreased outward currents formed by the potassium channels, whether IKR, IKS, or IKI, will all prolong action potential. Then if, in addition to this mutation, an individual now takes a medication that would further prolong the action potential, it's just like a second hit. So the duration of the action potential is further prolonged. And because the duration of the action potential is further prolonged, this predisposes such patients to having early after depolarization, because some of the calcium channels and the sodium channels that were previously inactivated would recover, and an action potential can be generated. And if it reaches a maximal limit, it can trigger an electric activity when the heart is still, when the myocardium or the myocytes have not even recovered. So this early after depolarization are usually secondary depolarizing voltages that can trigger an electric activity. And if this happens, it predisposes the patient to having dangerous arrhythmias, ventricular arrhythmias, Torsades de Pointes, and then sudden cardiac death. So this is a table that compares the commonest causes or commonest types of long QT syndrome 1, 2, and 3. So for type 1, okay, I can't really remove this from the top of the screen, but type 1 is the KCNQ1 gene is affected. Type 2 is the KCNH2 gene, and then type 3 is the SCN5A gene that is affected. And the protein affected in type 1 is both potassium channels are affected, but the IKS is affected in type 1, while IKR is affected in type 2, and then sodium channel INAL is affected in type 3. So the effect on the action potential is that all these will lead to, will prolong the action potential duration. And then the frequency, type 1 is commonest. It occurs in 35% of patients, while followed by type 2, which occurs in 30% of patients, and then type 3 is rare. It occurs in 10% of patients. And in the triggers of, they have various, these types of QT syndrome have various triggers. We have the, for type 1, long QT syndrome type 1, the trigger is exercise, like swimming, because during exercise, the sympathetic nervous system is activated, and in normal individuals with higher heart rates, the ventricular repolarizing time should shorten, and then also the IKS channel is activated, and this inhibits the early after depolarization that will usually occur with beta 1 sympathetic activation. So in patients who have a mutation involving the KCNQ1 gene, which codes for the IKS gene, this is deficient, the IKS is deficient, so this predisposes them to having early after depolarization, which would cause arrhythmias, Torsades de Pointes, and they can have sudden cardiac death. While for type 2, the main trigger is arousal, like usually auditory stimuli. For instance, alarm clocks can trigger events, because it's said that patients who have long QT syndrome type 2, this auditory stimuli causes a release of catecholamine into the circulation, and this is similar. It's just like a fright response. This will now lead to the occurrence of early after depolarization, because of the sudden catecholamine release and predispose them to having arrhythmias. While for type 3, the cardiac events usually occur at rest during sleep, even though the mechanism is not so clear, but it's said that during sleep in normal individuals, the sodium channels are usually they are activated during rest and during sleep. So individuals who already have a gain of function mutation of the sodium channel plus the normal activation of inward flow of sodium channel during sleep can trigger an arrhythmia in them, lead to formation of action potential, trigger arrhythmia. They can have Torsades de Pointes and then sudden cardiac death. Then the type 2 and 3 are commoner in females, while type 1 is commoner in males. The cardiac features of long QT syndrome, they may present with a history of palpitation, they may have dizziness, syncope. The syncope is the commonest symptom and it can occur without warning. There's usually absence of aura. They don't have incontinence, postictal findings. This helps to differentiate the syncope associated with long QT syndrome from that that occur during seizures, because patients with seizures may have aura, they may have incontinence, depending on the type of seizures they have. Then Torsades de Pointes may degenerate into ventricular fibrillation that can be aborted. They can also have aborted cardiac arrest. That's in places where they are well in hospitals, maybe they are well equipped and in developed countries, and they can also have sudden cardiac death. So Torsades de Pointes is a type of polymorphic ventricular tachycardia that is characterized on ECG by oscillatory changes in the amplitude of the QRS complexes around the isoelectric line. There are also non-cardiac manifestations of long QT syndrome, because there are some syndromes that are associated with that have long QT as part of their manifestation. So for instance, the Anderson-Tawil syndrome, which involves mutation in the KCNG2 mutation, is usually associated with prolonged QT interval. They can have episodic muscle paralysis, muscle weakness, facial dysmorphism. They can have dental anomalies and small hands and feet. Then also Javelin-Nelson syndrome, which involves mutation in both the KCNQ1 and the KCNE1 mutation, is usually associated with sensorineural deafness in addition with the long QT syndrome. Then Timothy syndrome, the mutation there is CACNA1C and usually associated with QTC prolongation. They can have syndactyly, autism spectrum disorders, intellectual disability, dysmorphic facial appearance. How is long QT syndrome diagnosed? There's a diagnostic criteria for long QT syndrome called the Schwartz score, and it has 3 components. There's an electrocardiographic finding. There's also clinical history, then family history. So under the electrocardiographic finding, QTC duration calculated using the Behçet's formula, if it's greater than or equal to 480 milliseconds, they score a point of 3. Between 460 to 472, 450 to 459, 1. Then QTC during the 4th minute of recovery from exercise test, if it's greater than 480 milliseconds, is a score of 1. Because then presence of Torsades de Pointes, score of 2, T-wave alternance, score of 1, notched T-wave in 3 leads, score of 1, then low resting heart rate, the score 0.5. Then presence of, for the clinical history, syncope, the score 2, congenital deafness, presence of syncope with stress 2, without stress 1, then presence of congenital deafness 0.5. Under the family history, family members with definite long QT syndrome, score of 1, then unexplained sudden cardiac death, the score less than in an individual less than 30 years among immediate family member, the score is 0.5. So for patients who have score of greater than 3.5, a definite diagnosis of long QT syndrome can be made. So between 1 and 3.5 is intermediate probability. The patient may or may not have. Then less than 1, low probability. For the management involves history, physical examination, investigation, and treatment. Historically, we can get a history of syncope. They can have maybe previous history of aborted cardiac arrest. Then also family history of syncope and sudden cardiac death, especially among young patients. Then on review of medical history from family members in places where medical records are being kept, we can find a history of QTC prolongation on EKG, and then they may have family history of seizure, maybe a syncope that is misdiagnosed as seizure. Then physical examination, majority of patients with long QT syndrome usually would not have any physical features, except those ones that are associated with non-cardiac manifestations. They are apparently normal. So, but rarely they may be accompanied with gene-specific extracardiac features. For instance, the Anderson towel, they have some dysmorphic features. The common investigations that will usually be done for patients with long QT syndrome include an EKG, and usually the heart rate corrected QT interval will usually be prolonged. They may have some ST wave changes, which can suggest the genetic cause of long QT syndrome. Then on exercise EKG, commonly they have usually the QT interval should shorten during exercise because the heart rate increases. So the ventricular repolarizing time should shorten, but this does not occur in patients that have long QT syndrome. Rather, it's even prolonged. Then in some cases, intravenous pharmacologic provocation tests can be done, usually with epinephrine, and this will demonstrate inappropriate prolongation of the QT interval. So this is like a flowchart showing the how the diagnosis is made from clinical presentation of an index patient, high index of suspicion. Then patient is assessed by taking medical history, symptoms, and then patient should be investigated using an ECG, 24 hours Holter, exercise testing as the case may be, and then other secondary causes of long QT syndrome should be excluded. For instance, drugs and electrolyte abnormalities that can prolong QT. Then we can calculate the heart rate corrected QT interval. So from the calculation, and then the Schwartz score also can be used to risk stratify patients. So for patients who have long QT risk score, usually using the Schwartz score, greater than or equal to 3.5, have a high probability of having long QT syndrome, while those who have between 1.5 to 3 have intermediate probability, and those who have long QT risk score less than or equal to 1 have a low probability, and alternative diagnosis should be sought. So this is the ECG pattern in patients who have long QT syndrome. The commonest ones, long QT 1, 2, and then 3. For long QT 1, they have a broad-based T wave. Then for patients who have long QT syndrome 2, their T waves are usually notched. They have 2 peaks. And then for the ones that have long QT syndrome 3, they have narrow spiked T wave. The treatment for long QT syndrome, beta blocker is the cornerstone for managing patients that have long QT syndrome. And usually, the non-selective beta blockers like nadolol, propranolol have been advocated. Metoprolol and atenolol are less effective and should be avoided. So what does beta blocker do? Beta blockers, they prevent the occurrence of early after depolarization by blocking the adrenergic driven boost of calcium currents. And this early after depolarization is what triggers the occurrence of arrhythmias in them. So only propranolol have been shown to reduce QTC heart corrected QT interval. Then for the long QT syndrome 3, where the mutation involves the sodium channel, so late sodium inward current blockers like mexiletine, flecainide, and ranolazine can be used. Then potassium supplementation has been shown to be effective for patients who have long QT syndrome 2. Then there is a drug called lumacaftor, which has been shown to shorten QT interval, especially in patients that have long QT syndrome 2. Then drugs that further reduces the repolarization reserve, drugs that will further prolong QT interval should be avoided. And then electrolyte disorders such as hypokalemia should be corrected. Then for patients who are already on beta blocker and still have symptoms, left cardiac sympathetic denervation has been shown to improve symptoms. Then device therapy is usually the final level of therapy in patients that have long QT syndrome. That's in patients who have been on beta blockers and still have cardiac events. So this is a flowchart that summarizes the treatment options available for patients that have long QT syndrome. You can see that use of beta blocker and ICD is a class 1A indication. However, for patients who have contraindications to ICDs, or maybe they reject ICDs, then left cardiac sympathetic denervation can be done for them. Then for patients who are symptomatic or have high risk features, beta blocker is still class 1A, but if they have symptoms while on beta blockers, or if beta blockers are not tolerated, then we can go further to either do place an ICD or left cardiac sympathetic denervation. In patients who are asymptomatic, in whom QTC interval is greater than or equal to 470 meters per second, beta blocker is class 1A. But if corrected QT interval is less than 470 meters per second, beta blocker is class 2A indication. So this just shows the treatment options available. Beta blocker usually effective in all the long QT syndrome, but more in long QT syndrome 1 and 2. Metoprolol is not effective. And beta blockers are less effective in patients that have long QT syndrome 3. So sodium channel blockers are usually not effective in patients that have long QT syndrome 1 and 2 because the mutation involves the delayed rectifier potassium channels, while long QT syndrome 3 mutation involves the sodium channel. So gain of function mutation of the sodium channel, so it's more effective in them. Then potassium supplementation is associated with significant shortening of QTC interval in patients that have long QT2, even though it's not generally used. So this shows the recommendation for the ESC 2022 guideline on the management of arrhythmias in patients that have long QT syndrome. And beta blocker, as I said earlier, is advocated, either nadolol or propranolol in patients who have long QT syndrome. And then mexiletine is indicated for patients who have long QT syndrome 3. And then ICD implantation may be considered in asymptomatic patients with long QT syndrome who have high risk profile. Then routine diagnostic testing with epinephrine challenge is usually not recommended, even though it can be done, but it's class 3, usually not recommended. So there's an mFACT risk score that helps to determine the probability, that helps to determine which category of patients would benefit from an ICD at presentation. So it helps to test the probability of a patient having an appropriate shock if an ICD is implanted. So it has it has four parameters. We have event-free, patients that have been event-free, and then they are scored -1, 0, 1 point, 2 points. So for patients who have been event-free on treatment, for instance, beta blocker, for more than 10 years, they score a point of -1. So for patients who have corrected QT less than or equal to 500, they score a point of 0. Then for patients who have a QT corrected interval of 500 to 520, they score a point of 1. And then for patients who have QT corrected, heart rate corrected QT of greater than or equal to 550, they score a point of 2. Then prior aborted cardiac events, if they don't have any, 0. If they have 1, then patients who have events while on treatment, they score a point of, if they don't have any, 0. If they have 1, then age at implantation, greater than 20 years, score of 0. Greater than or equal to 2 of 20, they score 1. So for patients who have points of mFACT risk score of greater than 2, it has been shown that they would have an incidence of ICD shocks at 4 years. They have is about 40%. So patients who have score greater than 2 will benefit from ICD implantation, but any patient who has a score of less than 2 will not really benefit from ICD implantation. So the risk of sudden cardiac death in patients that have long QT syndrome is just a graph, a bar chart showing the risk of sudden cardiac death in patients that have long QT syndrome during a 5-year follow-up. So patients who have the orange color indicates the risk of sudden cardiac death. So it's about 1.3%. That's in a study done by Schwartz in 1985, but the most recent one done in 2017 is about 0.05, probably because of improved diagnosis and treatment options. The causes of acquired long QT syndrome includes commonly drugs, antiarrhythmic drugs like amiodarone, dronedarone, procainamide, and antibiotics like the macrolide, fluoroquinolones, antipsychotics like chlorpromazine, haloperidol, antidepressants also like escitalopram, SSRIs like escitalopram and citalopram, then antiemetics like ondansetron, and then other drugs like methadone, chloroquine, donepezil can cause short QT syndrome. So the supportive care for patients that have, long QT syndrome. Supportive care for patients that have long QT syndrome is important to assess them for asthma, diabetes, depression, because the treatment that will be given to them involves the use of beta blocker, which can exacerbate the comorbidities they already have. And then correction of electrolyte imbalances too is very important. Then patients should have ECG monitoring during interventions that can precipitate arrhythmias. For instance, patients who are pregnant and maybe are going to have their babies, dental procedures, or endoscopy. Then drugs that further prolong QT interval should be avoided. Then patients who have long QT syndrome, 1, should avoid strenuous exercise like swimming that can predispose their arrhythmias. And then those who have long QT syndrome 2 should avoid loud noises, use of alarm clocks. And then individuals who have a high risk of having arrhythmia should avoid competitive sports. The surveillance, so patients should be routinely monitored, and the dose of beta blockers should be adjusted as they grow, especially for children. And then individuals who have ICD in place should have regular periodic assessment to check for inappropriate shocks, complications that could result from the ICDs. So pregnancy and long QT syndrome, for pregnant women are usually classified into 3: low risk, medium risk, and high risk. So for patients who have low risk, it means that they have long QT syndrome, but they've never had any cardiovascular event, and their QTC interval is less than 470. So they have level 1 surveillance. That means that they must see a cardiologist. And if they are on any medications that would further worsen the QT intervals, it should be discontinued. And they have to, the method and location of delivery must be recommended by their midwives. Then for patients who have medium risk, that's long QT syndrome with maybe remote events, maybe in the past, and they have no current events, and then QTC interval is greater than 470, that's level 2 surveillance. And that means that they have to be managed in a tertiary center. And also they should have like, they must be on beta blockers, intravenous line at the point of delivery in case of any emergency, any arrhythmia. And then they should also have, they should be in a center where cardiovascular defibrillator is available in case the process of delivery triggers an arrhythmia. Then for those who are high risk, they have long QT syndrome with recent cardiovascular event. So those ones need close monitoring. In addition to having to go into a tertiary center, the labor cesarean section is usually advised to shorten the period of labor, and they need continuous monitoring. They need to have a line in place, an arterial line, and preparation should be made in case they need IV antiarrhythmic drugs. So for women who plan on getting pregnant, women who have long QT syndrome who plan on getting pregnant, prenatal counseling is very important. Patient needs to be counseled on their diagnosis and the fact that if they have poor control of their arrhythmia, then they will need intervention. Electrophysiology can even be done for them. And then they need to discontinue drugs that are contraindicated in pregnancy. For instance, if they were initially on amiodarone, it needs to be discontinued, ACI or ARBs. Then when they are already pregnant, they need to avoid QT prolonging drugs, and then they need to take their medications, beta blockers, propranolol, for instance. Then if they have a ventricular tachycardia, they would need a temporary pacing, IV lidocaine or mexiletine. And then during labor, they will need analgesia to shorten, to reduce the pain, which can also be a trigger. Then after delivery, their babies need to be screened. They need to have ECG done for early diagnosis. So the first line drug that is used for treatment in patients that have unstable cardiac rhythms, in patients that are pregnant, is IV or oral beta blocker, depending on how stable the patient is. Then the second line is IV magnesium sulfate. Then the third line is transvenous pacing. Short QT syndrome is an inherited cardiac channelopathy that is characterized by abnormally short interval and increased risk of atrial and ventricular arrhythmia. And patients who have short QT syndrome usually have a short QT interval in the presence of a structurally normal heart and without any other comorbidities. So it is defined as a QTC interval less than or equal to 330 milliseconds, or less than, some people say less than 330 or less than 360, plus one of the following: history of cardiac arrest or syncope, family history of sudden cardiac death, or a history of death at the age of 40 or younger, family history of death at the age of 40 or younger, then family history of short QT syndrome. So it was first recognized, the first recognition of increased risk of sudden cardiac death with a short QT interval was first reported in 1993 by Algra et al. In a group of 6,693 patients. And then by 1999, Husak et al. Thought that there might be a relationship between the shortening of the QT interval in a young girl who died suddenly. Then by 2000, short QT interval was proposed. The name short QT interval was proposed. So, but a definitive link between short QT interval and familial sudden cardiac death was established in 2003, and short QT syndrome 1 was first described in 2004 by Brugada et al., while short QT syndrome 2 was first reported in 2000, also in the same year 2004 by Belloc et al. And then short QT syndrome 3 was reported in 2005. So by 2007, the other forms of short QT syndrome, syndrome 5 and 6 were reported. So the epidemiology of short QT syndrome, the real prevalence of short QT syndrome is difficult to establish because we have limited number of cases worldwide. However, the recent prevalence is about 0.02 to 0.1. So, but I couldn't lay my hand on any local study. However, Barine et al. Conducted a study using a database of 6.1 million ECGs from between 1995 to 2008. And the prevalence of short QT syndrome was highest in Black, 5.8%, followed by Caucasians, 3.2%, and Latinos, 1.8%. Another study done by Funada et al. Showed that among 10,984 Japanese patients, the prevalence was 50.2 short QT syndrome, and only three of them had 0.03% had short QT syndrome less than 300 milliseconds. So the genetic factors in short QT syndrome is usually due to a mutation affecting the function of ion channels, just like we saw in long QT syndrome. And the mutation either causes either hyperfunction of the delayed rectifier potassium current, that's a gain of function mutation. In long QT syndrome, it was a loss of function mutation, but here is a gain of function mutation in the delayed rectifier potassium current, or hypofunction, that's a loss of function mutation in the calcium current. And this will eventually lead to shortening of the repolarization period and an increased risk of transmural dispersion of repolarization. This will lead to, it creates a re-entry circuit which predisposes them to having arrhythmias. In this case, they have ventricular fibrillation, they can have atrial fibrillation. So 6 short QT syndrome subtypes have been discovered so far, and from 9 different mutations. So most short QT syndrome are usually familial, and the inheritance pattern is autosomal dominant. So this is a table showing the 6 commonest types of short QT syndrome. Gain of function mutation in the delayed rectifier potassium channel or loss of function mutation in the calcium channel is the underlying mechanism for short QT syndrome. Then there's an overlap between the genes that cause short QT syndrome and Brugada syndrome, and even long QT syndrome. So this just shows the overlap gene. We can see that short QT syndrome, the CAC-NB2, CAC-NA1, and then the SLC4A3 gene that cause short QT syndrome are also implicated in Brugada syndrome and also implicated in long QT syndrome. It's just that the mutation is opposite. For instance, the commonest one, the KCNH2, KCNQ1, KCNJ2, instead of loss of function mutation in long QT syndrome, is now a gain of function mutation in short QT syndrome. So there's an overlap between the genes. So in short QT syndrome, what happens is that the action potential duration is shortened because we have a gain of function mutation in the delayed outward rectifier potassium channels, and then a loss of function mutation in the sodium and calcium channel. So this will shorten the action potential. The mechanism of arrhythmogenesis in short QT syndromes is not well known. However, the effective repolarization and action potential duration is shortened, and this leads to a decrease in excitation wavelength and circuit type reentry. So because of the short QT interval, it predisposes them to having re-entry circuits, and this would predispose them to have ventricular fibrillation or atrial fibrillation. The clinical presentation of patients that have short QT syndrome range from, they could be asymptomatic in 40% of cases, and they could also have dizziness. However, the commonest symptom in a case series done by Gusetto et al. Shows that the commonest is cardiac arrest. And unlike in long QT syndrome, where there are some triggers that could predispose cardiac events, in short QT syndrome, there are usually no triggers, and the events can occur while at sleep, during exercise, after listening to loud sound. So there's really no trigger. And in 24% of cases, syncope is the first presenting symptoms. So they could have palpitation, they could have AF, atrial fibrillation, in greater than 80% of cases. So the diagnosis is based on a patient's family history, evaluation. We evaluate the patient using a 12-lead ECG. So they could have history of palpitation and syncope, family history of sudden cardiac death, or even atrial fibrillation at a very young age. So there's a short score. We saw a short score in long QT syndrome. There's also a short score that is used for diagnosing short QT syndrome. However, the components are a bit different. So for short QT syndrome, the diagnostic parameters include QTC less than 370 is called 1. Then less than 350 is called 2. Less than 330 is called 3 points. Then the J point, T point interval less than 120 milliseconds is called 1. Then for clinical history of sudden cardiac death has a score of 2. Documented polymorphic ventricular tachycardia or ventricular fibrillation, score of 2. Unexplained syncope, score of 1. Then atrial fibrillation has a score of 1. Then family history, score of, if there's a first degree or second degree relative with high probability of short QT syndrome, the score is 2. Then first degree or second degree relative with unexplained cardiac arrest, score of 1. Sudden infant death, score of 1. Then genotype 2 for patients who have genetic testing. Genotype positive is score of 2. And the variant of unknown significance could be a culprit, and it has a score of 1. So any patient that has a score of greater than 4 has a high probability of having a short QT syndrome. For patients who have score of less than 3, of 3, intermediate probability, score of 2, low probability. Investigations include ECG. They may have a short or even absent ST segment with a T wave that starts immediately after the S wave. Then the T wave may also be narrow, and it may be pointed symmetrical. They may have pointed symmetrical T waves. So this is an example of an ECG from a 65-year-old patient with short QT syndrome. And you can see that the ST segment is barely seen, and the T waves are tall and peaked. This is another ECG from another patient that has short QT syndrome. The first ECG, but the second one, it's a Holter, 24 hours Holter, which shows an irregular reading, most likely AF. So the electrophysiological changes that are observed in patients that have long and short QT syndrome, the differences now, the molecular mechanisms we have increased inward current or reduced outward current for short QT syndrome, and this the inward currents are calcium and sodium. The outward currents are potassium ions. While in short QT syndrome, we have reduced inward currents. We have reduced inward currents, or reduced outward currents rather. Then triggered activity earlier after depolarization is usually the trigger for long QT syndrome, but that's not the case for short QT syndrome. Then we also have the conduction velocity is either normal or reduced in patients that have long QT syndrome. It's also the same for patients that have long QT syndrome, but the action potential duration is increased in patients that has a long QT syndrome, but it's reduced in patients that have short QT syndrome. Then the effective repolarization potential is increased in patients that has a long QT syndrome and reduced in patients that have short QT syndrome. So this is just another table that shows the differences between short and long QT syndrome. So the other features that can be seen in patients that have long QT syndrome is that the QT heart rate slope is significantly flatter in patients who carry the pathogenic variants in KCNH2 gene. And then the QT adaptation to standing is reduced compared to the values for normal population. Investigations, the other investigations include electrophysiological studies. However, the role in patients that have short QT syndrome is still very controversial. And the 2015 ESC guideline states that invasive electrophysiological studies usually not recommended. Then we can also do genetic testing for them. However, the genetic testing, the contribution is not clearly defined, and a negative test does not rule out the presence of a short QT syndrome. For the treatment, ICD is the effective treatment, and however, there's an increased risk of inappropriate shocks, especially due to sinus tachycardia, atrial fibrillation, tall and narrow T-wave oversensing. And then quinidine is the most effective pharmacological therapy in patients that have short QT syndrome because it blocks several potassium channels. IKR, that's the delayed outer rectifier potassium channel, then the transient outward potassium channel, then the delayed inward rectifying potassium channel, IKS. So, but another drug that can be used in the treatment of patients that have short QT syndrome is disopyramide. It's an alternative therapy for short QT syndrome, but ibutyl, sotalol, and really not effective in patients that have short QT syndrome. So this is just a guideline on the management of arrhythmias for patients that have short QT syndrome, and genetic testing is indicated in patients who have a diagnosis of short QT syndrome. It's a class 1A recommendation. And short QT syndrome should be considered in the presence of a QT interval less than 320, class 2A recommendation. And if a patient has a heart rate corrected QT interval greater than 320 and less than 360 with arrhythmic syncope, QT interval short QT syndrome should also be considered, but that's a class 2A recommendation. Then ICD implantation should be considered in patients who have short QT syndrome with arrhythmic syncope. That's also a class 2B recommendation. And then quinidine is considered as a treatment choice in patients who have short QT syndrome if they qualify for an ICD, but they have a contraindication or refuse to take it, or if they're asymptomatic but have a family history of short QT syndrome, class 2B recommendation. So the prognosis of patients that have long and short QT syndrome, most patients with short QT syndrome present with symptoms such as palpitation, atrial fibrillation, syncope, and sudden cardiac death. So the prognosis is not so good. And even if patients who have long QT syndrome will still continue to have cardiac events despite maximal therapy. So it's important that risk assessment and individualized treatments be done to ensure a good long-term outcome. So this is just a picture, a table that shows the differences between long QT syndrome and some of the other cardiac channelopathies like Brugada syndrome and catecholaminergic polymorphic ventricular tachycardia. In conclusion, long QT syndrome and short QT syndrome are electrical disorders of the heart that can increase the risk of sudden cardiac death via development of malignant arrhythmia. Even though short QT syndrome is rare, it's life-threatening. And inherited heart disease presenting with sudden cardiac death or aborted sudden cardiac death occurs in 34% of patients who have a family history of sudden cardiac death. So with careful evaluation, risk stratification, and treatment, most patients with long QT syndrome will remain asymptomatic. These are my references. Thank you for listening.
Dr. Conte. Okay, thank you. Okay, Dr. Conte.
Yes, sorry. Thank you very much, Dr. Awodi, for a very extensive presentation. So at this juncture, I will open the floor. If we have questions or concerns, then we can raise them. Okay, Sambo is saying, wow, great presentation. Dr. Brown is saying, thank you. Dr. Awodi, I got a little bit confused with the use of quinidine in the short QT syndrome. Because you made a statement that the long QT syndrome, you tend to get increased inward current, so gain of function in the sodium current, and then loss of function in the potassium current, okay? Yes. So that is for long QT. And then for short QT is the reverse. You rather have loss of function in the inward current and then gain of function in the outward current, okay?
Yes.
So, but then the quinidine is a potassium channel blocker, isn't it?
Yes, sir.
Then how does it produce its benefit? How does the benefit comes about in short QT? When in short QT syndrome, you actually have reduction in the inward current.
Well, for short QT syndrome, it has been shown that ICD is the preferred treatment of choice. And even in the ESC guideline is a class 2 recommendation, but the most effective treatment is ICD implantation.
Okay.
Yes, sir.
And then also in terms of for the long QT syndrome, making the decision to put an ICD, I see the main indication is after an aborted cardiac arrest. But
Yes,
however, in the long QT syndrome, long QT3, most of the cardiac arrest will occur while they are asleep.
While they are asleep.
So you won't get time to witness an aborted, cardiac arrest to make the decision to put in the ICD.
Yes, sir.
I'm just thinking that, like, for the long QT3, I mean, the criteria should be relaxed a bit, because you would hardly witness, if they do have the arrest, you will hardly witness, they'll just die in their sleep.
Yes, but there is this mFACT risk score that can be done at the point you're seeing them.
Okay.
So it helps to predict the probability that a patient would have a shock, like ICD shock at 4 years, an appropriate shock at 4 years. So if that score, if the patient is risk stratified using that score, it helps to determine the people that will benefit from an ICD at the point they are being seen.
Okay.
At initial presentation, even before they have the cardiac events.
Okay, thank you. Lalikan is posting a question. He's saying, thank you for the wonderful presentation. I noticed that you stated that short QTC is less than 330, and some places you said it's less than 360, and also greater than 320. Which one do we select? It's a bit confusing.
Well, from the ESC, actually, there are different Let me share my screen again. From even the ESC, they have like different, it's not really unified actually. Like different authors have different cutoff range. It's not unified. However, if short QT syndrome should be considered in the presence of, if a patient has a heart rate corrected short QT syndrome less than 320, so the diagnosis of short QT syndrome can be made. However, even if a patient has a short QT syndrome, a heart rate corrected QT interval of greater than 320 and is less than 360 plus an arrhythmic syncope, so a diagnosis of short QT syndrome can still be considered. So even if it's longer than the is more than 320 and less than 360, but the patient has had an arrhythmic syncope, so the probability of QT syndrome is still high. And then when you now use the Schwartz score, it can also help you to make the diagnosis of short QT syndrome. So between 320 and 360, the diagnosis of short QT syndrome can still be made. If a patient has a family history, for instance, of sudden cardiac death, a family history of short QT interval, risk of a patient who has a family history of sudden death before the age of 40, a high index of suspicion is needed. So it's not only the QT interval that is used for the diagnosis.
Thank you very much. So for these patients, you know, especially those with a long QT syndrome. So if, for instance, you pick them up during routine screening, like say they're just getting screened to partake in a sporting competition, and then you pick a long QT syndrome, do you forbid them from taking part in the sport, or you can put them on medication and allow them to partake in a sporting event?
Okay, so it's just that in our environment, we don't really have the facilities, but ideally, in places where they have the facilities for genetic testing, if the particular gene implicated can be identified, because some of the long QT syndrome, for instance, if a patient has long QT syndrome 1, competitive sports are usually not advised because those strenuous exercise can precipitate a ventricular arrhythmia, like Tozatis de Pointes, for instance, swimming and other competitive sports. So it's usually not advocated depending on the type of long QT syndrome they have.
Okay.
Okay, thank you very much for the presentation. Just a quick one. In long QT, you mentioned two syndromes. Roman Watts occurs in autosomal dominant. What are the other components again? And the second one you say occurs in autosomal recessive with deafness. What are the components again? Sorry. Just a quick recap.
The autosomal dominant one, Roman Wald, have long QT syndrome, but they don't have deafness. It's just that they are different genes. For instance, the Roman Wald, about 9 different genes are implicated, while for the Lange-Nielsen, they have long QT syndrome, but they have congenital sensorineural deafness, and 2 genes have been implicated. So it's inherited in an autosomal recessive pattern, while the Roman Wald is autosomal dominant pattern. But if you look at the class, because more than 1 gene is implicated, it's not on that table that shows the different genes implicated in long QT syndrome. So they have Mendelian inheritance pattern. So it's not just 1 gene that is affected in them. So the difference is just that the pattern of inheritance and then the absence or presence of sensorineural deafness.
All right. Thank you.
Okay, so in the chat, a lot of people are applauding you. Dr. Kalamama says, excellent presentation. Dr. Ojo also is thanking you for the presentation. Dr. Cyril. Okay, Dr. Itubi also thanking you. Dr. Ampofo is clarifying something. He's saying, just for clarification, please, did you say quinidine affects the potassium channel? Thought it was mainly class one. It's mainly class 1 affecting sodium channel, and that will explain why it can be used for short QT syndrome.
Okay. So let me just see. Okay, it's the well, that's what I saw, that it blocks several potassium channels. IKR, IKS, IK1, and then the flow of calcium and sodium in addition.
That potassium aspect is new, because from the Vaughan-Williams classification, it's mainly purported as a sodium channel blocker, affecting the initial phase of the action potential. That was the same confusion.
Yeah, I'll go and
also
check.
having,
Okay,
so.
I'll check again, but that's what I saw. Okay. I'll check again, sir.
Correct.
Okay.
You are correct. They basically block the sodium channel, but they have additional effects on the potassium channels. They say some of the class 1A have that additional effect, and an example of that is quinidine. So it does both. You are correct.
Thank you for the clarification. Thank you.
Okay. Are there any more questions from participants? Any more clarification? Okay, so copy around. No. Okay, Chief Okope is not on. I'll call on our chiefs to make their comment. Chief Allison, if you can please make your comments on the presentation.
Yeah, thank you so much, Dr. Conte. I was really appreciate the presenter. Sorry, I don't know how to pronounce your name, but that was a really excellent, great presentation. Although I was multitasking while you were presenting, but the ones that I listened to were quite fascinating. You touched on most MCQ questions, which are the places where these will come out from, really the areas that are needed. So I must really appreciate you on behalf of those who for exams. Thank you so much. We appreciate the efforts that you have put into it. Thank you. I don't want to draw us back, but I'm quite sure that you mentioned the medications that are associated with long QT syndromes. You gave the list of the medications that are associated with long QT syndrome. Sorry, am I audible?
Yes, ma.
Okay, so you gave examples of the medications that are associated with long QT syndrome.
Yes, ma. Yeah, I gave just
Okay.
a table. Let me go to this.
Okay. If the table is exhaustive, then and that will be fine. Aside the, let me just, because there are some MCQ questions that come out that will need, sorry. Okay, we used, okay. You didn't classify the antiarrhythmics. Okay, that's fine. That's fine. It's like a summary, but we should know that class 1A and sodium channel blockers, then class 3, those are the two. So we can now give so many examples there. It comes out in MCQ, especially quinidine, procainamide, and I think pyramide too there. Then for the class 3, amiodarone, sotalol, ibutylite, dronadarone, all those ones. Then antipsychotics, like I have said, antibiotics. The antibiotics, you know them easily. The usual problem is these antiarrhythmics, actually. The antiemetics, we will know them when we see them. Antipsychotics, we will know them when we see them. The confusion, just like Dr. Conte is asking, especially if you've read this, you need to read it over and over again, because there's always confusion, long QT, short QT, and with these anti-arrhythmic drugs. But I don't know how we can code that, but we just have to cram it, because we'll see, we are likely going to see them in MCQs. So we already have an idea of the electrolytes that will be implicated in these QT syndromes, the long, the short. I think we've treated so many MCQs on that. So we could just revise that on our own and just check. But by and large, I think you've really done well. But I'll still like to state that for those going for exams, we should check up Rugada and some other channelopathies like this catecholamine and tachycardia. You understand? We should check those two and come in OSCE. I know she mentioned a lot about them, but we should still Bugada. I'm suspecting that Bugada. I wouldn't know why. So please let's check up Bugada syndrome. That one can come out in long case. I think that's about all. Well done. Thank you so much.
Thank you.
Okay, thank you very much, Dr. Imolade. I don't know, I think Dr. Adeanju is not with us today. So
hello, Conte.
Yes, please. Yes.
Good evening. Sorry, I'm just looking at the slide that is just projected. I see 440 for men and 460 for women. I thought some literatures I've come across for men use 450 and 460. I don't know whether she came across the 450 for men.
Dr. Awudi, you want to respond to that?
Thank you. The problem is they are different. I saw different like values, but the one from ESC, the cutoff for long QT, if it's greater than, for short QT, 320 to 360. But I also have a table that shows the difference depending on the age. Depending on the age of the patients, normal, using the Bazet corrected formula. For females, 440, 450, sorry, for males, 430. It's prolonged if it's greater than 450 for males, and females 470. However, in the ESC, then the cutoff for diagnosing long and short QT syndrome is still different, even though generally if corrected QT interval of greater than 470 in females and 450 in males is considered prolonged, but the cutoff for diagnosing either long or short QT interval is still different. So for long QT interval greater than 480, short QT interval less than 320, or even if it's greater than 320 but less than 360, in the presence of either family history of sudden cardiac death, at an age less than 40 years, a history of ventricular syncope, you can still make the diagnosis of short QT syndrome. This is all I have to say. So greater than 480 is considered is a cutoff for diagnosing long QT syndrome. However, if it's greater than 470, it's already prolonged. But the diagnosis of long and short QT syndrome is made in the presence of other clinical and electrocardiographic features rather than the QT interval alone. That's what I saw.
Yes, thank you very much, Dr. Awode, once again for a very comprehensive presentation. So, in the absence of any further concern, we'll move to the next segment of this session. Dr. Awode, if you can please stop sharing your slide.